Good morning, everyone, or good afternoon. Welcome to the breakout session. The topic for this session is going to be gender, sexual and reproductive health and rights, and universal health care coverage in the context of the COVID-19 pandemic. Thank you so much for joining us. My name is Aletha Akers. I am the Vice President for Research at the Guttmacher Institute, a leading research and policy organization focusing on advancing sexual and reproductive health and rights, both within the US and globally. I want to welcome you all to this morning's session. We have a number of speakers who are going to be sharing on the topic for our breakout session this morning. But before we actually get started, we wanted to do several poll questions with the audience just to set the stage. If you could go ahead and put the first poll question up, please. Wonderful. Just for orientation, there will be 3 poll questions. You should see an option to select a response. Oh, many people are already answering. Fantastic. Please go ahead and enter your responses. I'll read the question. Have sexual and reproductive health and rights been a priority in the COVID-19 response? Yes or no? I'll give a few seconds for folks to answer. So you should be able to see the results from our first question. It looks like most of our respondents feel that no, sexual and reproductive health and rights have not been a priority during the COVID-19 response, which is part of the reason why we are going to be speaking about this topic this morning and how we can hopefully change that moving forward. Can we go ahead and put the second question up? Our second question is, according to estimations worldwide, how many unintended pregnancies could be increased by COVID-19? Is it 1 million, 5 million, 10 million, or 15 million? And the estimation from our audience today is about 10 million unintended pregnancies could be increased by the COVID-19 pandemic. And our third question is, what's the main cause for the lack of progress on Srhr during the COVID-19 pandemic? Is it political will? Is it lack of evidence, changes in priorities, or lack of resources? So the audience feels that it's generally been political will or the lack of political will that is the cause for the lack of progress on Srhr during the COVID-19 pandemic. So thank you everyone for engaging in those 3 poll questions this morning. I think they're a great introduction to this morning's session. And as our audience has indicated, Srhr has unfortunately not been well prioritized during the pandemic. This has been a very challenging time globally, as well as for countries, for providers in countries, and most certainly for patients, with some individuals tremendously impacted, negatively impacted by this pandemic. And those most affected have been those who have been the most marginalized even prior to the pandemic, which tends to be women, adolescents, and those living in poverty. The lack of access to universal healthcare coverage globally and definitely within certain specific countries has deepened these inequities, which is why we're speaking about this topic this morning. With regards to the second polling question, in terms of the number of people who could be impacted by unintended pregnancies, the estimate from our audience was about 10 million, and it's actually 15 million. So a significant number of individuals are at risk for experiencing this outcome. So with this, this is a way for us to introduce to our speakers this morning who are going to talk not only about what they've been seeing on the ground or at the level of healthcare systems or globally, but we're going to take the lens of what are some of the learning lessons that can be applied as we move forward. How can we build back better? What are some suggestions? In the interest of time, I'm going to have each speaker introduce themselves as part of their remarks. Each has 4 minutes to give their presentation, and then we will open it up for questions. If you have questions that come up during the course of the comments, please feel free to enter them into the Q&A, and I will be reviewing those and using those for our conversation after the presentations. So with that, I'm going to turn it over to our first speaker, who is going to be Dilly Severin. Dilly.
So thank you so much for having me today. Good morning, good evening to everyone. I'm really grateful to be a part of this important conversation and to share a bit about FP 2020's work, and in particular, in response to Dr. Aker's question about what we can do to build back better, share a bit about a relatively new toolkit we released called the Ready to Save Lives Toolkit, which focuses on preparedness and which we hope can be a resource in this time of ongoing crisis. So my name is Dilly Severin. I'm the Senior Director of Global Initiatives at FP 2020. And FP 2020 is a global partnership which seeks to empower women and girls by investing in rights-based family planning. Over the past 8 years, we've worked with government, civil society, multilateral organizations, donors, and the private sector to ensure that all women and girls have access to the high quality family planning services and supplies that is their right. But we are in some pretty challenging times. And so why focus on preparedness? As I mentioned, the focus of that toolkit, everyone here knows, and I think your poll responses reflect how deeply the COVID-19 pandemic has disrupted health systems around the world. But who has been most affected? An August survey from the World Health Organization showed that other than routine immunizations, family planning was the most disrupted healthcare service. So that's the case even though women and girls around the world, for them, family planning is critical basic healthcare. So think about the magnitude of this disruption and the fact that even before COVID, we already had 218 million women with an unmet need for family planning. So for FP 2020, when we thought about the need for preparedness and for a preparedness toolkit, fundamentally, it really is about realizing that as we strive toward the achievement of universal health coverage and the SDGs, preparedness in and of itself is a form of insurance against the loss of progress due to crisis. So the most important question that we want to grapple with today is what really can we do? I think it goes without saying that whatever we think about and whatever our responses are, they must be grounded in a rights-based approach. Additionally, we think there are 3 things that are helpful in terms of building resilience against crises. Building political will, which was reflected in our last poll question, protecting the system we have, and adapting for the future. So in terms of building political will, everyone has a role to play here. We have to continue to join together with global and national partners, including the UNSG, WHO, PMNCH, UNFPA, and of course, and most importantly, country governments, to ensure the provision of family planning as an essential service. In terms of protecting the system we have, I think we all have come to terms with the fact that there likely won't be a going back to normal. So we have to ensure the sustainability and scale up of innovations and interventions that have proven effective during the pandemic, such as telehealth and self-care. And then adapting for the future. We have to help policymakers prepare for crises to come. And that is really what we hope the Ready to Save Lives toolkit can do. And in terms of what that adaptation looks like, I have this slide up. So I'll talk you through what's on here. In terms of what we can do to help policymakers, the first is building awareness and generating political will at the local level for Srhr preparedness and emergencies. And that's reflected in that initiating step you see on the slide. Secondly, helping policymakers assess local gaps and capabilities. And you see that as the second assessing step on the slide. And then the last piece of adapting for the future is strengthening the health system to deliver the minimum initial service package of Srh, ideally within 48 hours of an onset of emergency. And that's that implementing stage you see here. So really, to close, preparedness is so important, not only because it ensures that we are fulfilling our promises to women, girls, and vulnerable communities around the healthcare they deserve, but it is perhaps the greatest insurance we have to ensure progress, even in the face of crisis. Thanks.
Next, we have Anushka Kalyanpur.
Hi, everyone. My name is Anushka Kalyanpur. I am a CARES team lead for sexual reproductive health and rights in emergencies. I'm presenting on behalf of CARE, and I wanted to start with, our health equity and rights vision, which is really to support the fulfillment of health rights through community-centered, equitable, resilient, and responsive health systems, with SRHR at the heart of its programming across the emergency to development continuum. We believe the leave no one behind aspect of universal health coverage is paramount to achieving the Sustainable Development Goals. Therefore, when COVID-19 hit, we were guided by the principle that the efficacy of CARE's and others' COVID-19 responses really depends on understanding how marginalized people are affected in all their diversity across contexts and over time. As women's needs are routinely overlooked without deliberate efforts to fill persistent gender data gaps, we sought the advice of experts, women, and crisis-affected communities themselves. Data from across 55 rapid gender analyses across 55 countries indicate several cross-cutting themes expressed by women, including losing access to services for SRHR and increasing levels of GBV. Women are nearly twice as likely to report access to and quality of health services as a challenge than men, and 27% of them in the data set rated this as a top challenge. Women face social limitations on their mobility, rely more on public transportation, often need a man's permission to get healthcare, and spend more time on unpaid care than men, all of which restrict access to services. Lack of trust in the health system and diversion of female health workers away from their regular jobs to COVID services has sharply reduced access to SRHR, including family planning. So essentially, thinking about this, the results of these rapid gender analyses, this informed CARE's COVID-19 health response. And I'll share a few key adaptations and learnings that have come out from across our country offices. One, just to quickly mention, building on Dilly's point, about ensuring that the life-saving services in line with the minimum initial service package are available from the very beginning. So we collaborated with IWAG, the Interagency Working Group for SRH and Crisis, to adapt the MISP guidance for COVID-19. Secondly, we work to leverage community groups for risk communication and community engagement. We've heard a lot about this two-way dialogue to address myths and misinformation around COVID-19, but what we learned is it's important to utilize this RCCE framework to actually address issues on SRHR as it relates to COVID. For example, in Cox's Bazar, we heard that there were religious beliefs among the Rohingya community that if they died from COVID with foreign particles, like an IUD or implant, that they would be denied a proper Muslim burial. So there was actually a sharp decline in the uptake of LARC services, and in fact, increased demand for removal during the lockdown period. Another point to highlight is locally driven accountability mechanisms are not only programmatically feasible and effective, but also critical in ensuring continuity of rights-based SRHR to be responsive to those most marginalized, including in complex humanitarian crises. For example, the Center for Reproductive Rights and CARE Uganda, in partnership with women-led community structures, are addressing gaps in accountability by working with district-level duty bearers and rights holders in refugee settlements and host communities to identify SRHR issues, generate locally driven solutions to inform recommendations and response plans at those three different levels. For example, complaints collected through the accountability mechanism have contributed to SRH service referrals being ensured through COVID-19 coordination mechanisms. It's adapted the distribution of strategies for SRH commodities, reaching adolescents and other marginalized groups. Another point to highlight is, it's important to protect frontline health workers, not only in terms of infection prevention control and providing them with PPE, but also ensuring that we are supporting them through psychosocial support. We've been doing this in contexts such as Colombia, where people are already under a lot of stress with the refugee crisis there. A few other things to highlight, which I think my colleagues have maybe referenced: digitization in the context of telehealth, for example. Of course, investing in women leaders and youth leaders. There is just so much out there. It's so clear that when we actually invest in that leadership, we have responses that are much more responsive to the needs of the most marginalized. Mobile services have really been crucial to improving access for folks really in that last mile and most marginalized. Cash and voucher assistance have also been crucial in overcoming financial barriers. I'd like to end by really highlighting that it is crucial to invest in participatory accountability efforts to ensure that no one is left behind. And that's really crucial for achieving universal health coverage in COVID-19 and beyond. Thank you.
Our third speaker is Therese Gael Bajang, who's going to say her name far more beautifully than I'm sure I just did. Please, Therese.
Bonjour à tout le monde et merci de me passer la parole. Alors, c'est un réel privilège et honneur d'être ici parmi vous aujourd'hui. Alors, je suis le docteur Therese Gael Bajang, je suis gynécologue et obstétricienne au Cameroun. Je suis membre du mouvement Women in Global Health du Cameroun et je vais vous présenter la vision de Women in Global Health par rapport aux droits en santé sexuelle et de reproduction aujourd'hui. Et pour cela, je vais partager mon écran. Alors, la problématique principale que nous avons retrouvée, c'est que les services dispensés par les femmes sont dans un secteur qui est dirigé par les hommes. En effet, nous avons réalisé que 70% des personnels de santé dans le monde sont des femmes, mais par contre, elles n'occupent que 25% des postes à décision. Et nous pensons qu'il est donc temps de changer le discours et de ne plus victimiser les femmes, mais de les considérer aujourd'hui comme des agents de changement. Alors, il est essentiel de recenser et de souligner tout le travail qu'accomplissent les femmes dans le secteur sanitaire et social, qu'ils soient rémunérés ou non, et d'intégrer ce travail non rémunéré au marché du travail formel. Nous voudrons aussi qu'il y ait une réforme du système et de l'environnement professionnel pour offrir un travail décent aux femmes et combler les écarts entre les sexes en matière de rémunération et de leadership. Nous voulons réorienter la recherche, surtout dans le domaine des personnels du secteur sanitaire et social dans le monde, en particulier dans ce contexte de COVID-19. Et cette recherche doit porter en priorité sur les pays à revenus faibles ou intermédiaires pour évaluer donc la viabilité et l'efficacité des mesures et éclairer donc l'action qui vise à faire évoluer la situation des femmes. Concernant la couverture santé universelle, Women in Global Health s'est penché sur la question et nous voulons vraiment être une plateforme pour toutes les voix et nous avons décidé que pour renforcer la couverture universelle, nous proposons de catalyser une approche transformative des tests diagnostiques selon les genres. En effet, nous nous sommes rendus compte qu'une bonne prise en charge repose sur un bon diagnostic, mais malheureusement, peu de pays en Afrique francophone ont une liste de tests diagnostiques essentiels et les femmes très souvent se retrouvent en retard dans leur prise en charge car soit elles n'ont pas accès au testing pour des raisons financières par exemple, ou encore elles n'ont même pas le temps pour pouvoir le faire parce qu'elles doivent vaquer à leurs occupations domestiques, les tâches ménagères, la garde des enfants. Au Cameroun, hormis le contexte COVID-19, en 2019, les femmes consacraient encore 8,2 heures de plus par semaine que les hommes aux travaux domestiques qui n'étaient pas rémunérés. Il y a donc un manque important dans l'investissement des tests qui permettent le diagnostic des pathologies spécifiques aux femmes et il existe peu de données et de recherches faites sur leur accès aux tests diagnostiques. Un des principaux objectifs de Women in Global Health est donc de faire comprendre que la bonne adéquation des genres en santé globale est une affaire pour tous, qui s'applique dans tous les secteurs, dans tous les pays et pour toutes les personnes. Et notre stratégie pour 2020-2025, c'est de pouvoir mobiliser les ressources, de promouvoir le changement et de susciter des engagements et enfin responsabiliser les leaders pour une santé équitable entre les genres. Merci.
I really want to thank again our three speakers for their remarks this morning. We've heard three very different perspectives. First, we heard about the importance of understanding from a systems standpoint, what are some of the challenges to incorporating a gender lens into our health systems, of having universal health care available, and what really underlies challenges in the exercise of political will. There may be will, but the activities may not align. And what are some of the challenges and what are some of the suggestions for addressing that? We also heard from the perspectives of women in the field. What are some of the challenges in a pre-pandemic situation that can make it difficult to access sexual and reproductive health services? And in what ways does really an emergency situation, context, really make those more challenging. In addition, Anushka touched upon what are some of the important issues to consider from a local context or a cultural context that may impact access and care. How do we need to tailor our systems? And finally, we heard from Therese, who spoke about, from a provider's perspective, to discuss what are some of the challenges in women's day-to-day lives that can make things really more difficult, and how we can think about those as we consider what are some of our opportunities for moving forward. So with that, I'd like to transition into the Q&A portion of this morning's discussion. And I'd like to start off with a very general question that I would like for each of our panelists to consider. And that is, while the COVID-19 pandemic is new and remarkable because it is a new viral strain, pandemics are not new as challenges to health systems. From the SARS pandemic to Ebola, we have experiences globally. Our health systems have experiences and have had measures in place to deal with pandemics. What happened in this particular pandemic that made it challenging for us to appropriately step up and manage the pandemic at the health system level, particularly with regards to SRHR? And Dilly, do you want to lead us off with a response?
Sure, I'm happy to. It's a complex question. I think there are a few things going on here in terms of, despite all of the different pieces, what's been going on. I think one of them is just when we look at the fact that even though we've made a lot of progress, when we look at, I think, 2017 OECD data on funding for humanitarian aid, we see that 84% went to emergency response, while only 8% was for disaster prevention and preparedness. And then when you think about preparedness as a field, it's actually relatively new. So many tools exist, but often in disparate places, and policymakers are either not aware of them or don't know where to access them. So I think one of the places that FP 2020 has been thinking of, and one of the goals of this toolkit has been to kind of take the guesswork out of preparedness for policymakers. The toolkit, for example, compiles more than 30 different resources in one place, so policymakers can have the needed tools at their fingertips as they plan to just enable this preparedness, so that next time we will not be in the same situation as we are as in COVID. The final piece I will say is, at the beginning when I spoke, I mentioned the fact that even though we've made incredible progress, we still have women with an unmet need for family planning. And within that, almost every country is still struggling to meet the unique needs of adolescents and youth and vulnerable populations. And as we saw from the ECHO trial, really to provide the integrated services that ensure the highest quality of care. So I think if you have that as a context before COVID even arrives, if you add COVID to the mix, you can see how these challenges only become magnified.
Absolutely, thank you. Anushka.
I was also going to respond on preparedness because I completely agree with Dilly. I think that has been such a key eye-opening fact. I think often in our field, we think of, development and emergency, but we know that that's not the case, right? We really need to be integrating elements of preparedness as it relates to SRH and pandemic preparedness at the various levels. Dilly mentioned a lot about that systems level, but I would really advocate that we push even further to think also about that community level preparedness. There's a lot of work out there around, community-based preparedness as it relates to gender, SRH. I think those really need to be scaled up in addition to the work around the community-based surveillance, contact tracing, etc. I would say if we could really double down on the investment in local leadership, because we've seen when the folks from the global north have not been able to deploy it's truly been the frontline health workers and the community leaders who have, and including women and youth, who have really really led their responses in such incredible ways. So that's what I would say. Thank you.
Wonderful. And Therese, learning lessons from pandemic planning and translating that into this current context, some of those challenges.
Effectivement, alors je pense que mes collaboratrices ont déjà dit un certain nombre de choses. Alors je pense que, comme Anouchka, nous devrons vraiment essayer d'entrer au niveau de la communauté. Bon, je vais prendre le cas spécifique de l'Afrique francophone, où le système socio-culturel considère encore les femmes comme des personnes qui doivent rester dans les foyers et qui s'occupent essentiellement de la gestion de la ration alimentaire, la gestion de l'éducation des enfants à la maison. Et elles ont quand même des groupes de communication entre elles, des groupes de femmes. Et je pense que c'est là où il faudrait agir, en fait. Donc, il faudrait qu'on investisse ou qu'on entre dans ces groupes de femmes, ces groupes communautaires, pour pouvoir donc donner cette parole à ces femmes qui peuvent venir avec ces solutions, avec toutes les suggestions qu'elles ont donc, sur un plan national et sur un plan international. Il est vraiment important d'entrer dans la communauté pour pouvoir trouver une solution définitive à ce problème. Merci.
Thank you. Some really useful words for our participants. The importance of thinking about preparedness alongside development, as well as creating solutions for taking the guesswork out of preparedness planning. I think that was really well said. And thinking about how all of us might contribute to putting tools in place for our policymakers. Thinking about community level perspectives and how we can incorporate the perspectives of local leaders in helping with planning, which at its heart includes thinking about the role of women's voices and coming up with solutions that will be uniquely address their needs. I want to pick up on two points that were made in all of your remarks. One is about the importance of having a gender lens and the challenges and importance of thinking about SRHR, access and services for adolescents. I'd like to start with the gender lens. Why is having a gender lens really important in an emergency response? I'll start, Anushka, with you.
Sure. So, we know that in emergencies, people across diverse genders have different needs, capacities, and coping strategies. And we also know that our humanitarian response can increase, reinforce, or reduce existing inequalities. So if we really think about the gender, social norms, power dynamics, pre-pandemic and how pre-crisis or including with the pandemic, and how that's changing as a result of that crisis, that can really help us inform strategies that are more equitable and have that gender lens. So there are so many different ways for us to do that. I talked about the rapid gender analysis and how crucial that is to do at the beginning of a crisis. We have various different approaches at CARE and other organizations, of course. One maybe to highlight is, something we've put together recently. We call it the Srhr in Emergencies Minimum Commitments for Gender and Inclusion. And what it is based on inputs from our field teams all over the world, we've come up with 5 key kind of commitments across the project cycle. And so it's almost like a self-assessment questionnaire of about 20 questions that people can use on a periodic basis, even during a crisis response, to ensure that our programming is more gender sensitive and inclusive, and kind of take actions based on those reflections to really meet the needs of those most marginalized. So I think I'll pause there. Thank you.
Thank you. Gaëlle?
Alors, comme je l'ai dit tantôt pendant ma présentation, il faut vraiment qu'il y ait une équité entre les gens dans cette réponse au COVID-19, parce que comme nous l'avons vu, les personnels de santé, surtout sur le terrain, ce sont des femmes. Alors, les femmes représentent une bonne proportion de ces acteurs principaux, de ces acteurs qui sont devant, et nous devons vraiment les potentialiser et nous devons reconnaître leurs efforts. Et surtout, les femmes, elles font beaucoup d'autres actions qui ne sont pas souvent considérées et qui ne sont surtout pas rémunérées. Par exemple, elles vont faire des discussions, elles vont organiser des petits topos, des discussions avec les patientes qui viennent à l'hôpital et même souvent sur les réseaux sociaux. Donc, elles vont être très actives, mais malheureusement, on ne va pas reconnaître ce travail qu'elles font. Donc, c'est ça principalement, en fait, donc, reconnaître le travail des femmes et vraiment les mettre en avant pour avoir cette émergence.
Thank you. And Dilly, I want to go to a question in the Q&A that is related to this, but that I think you're especially poised to answer. What promising mechanisms are out there to effectively integrate gender and health programs when the two usually sit in different sectors and with limited collaboration between the two?
Thanks. No easy questions. I think the first thing I would say, and I think has been echoed by my panelists, is just overall stressing the important role of advocacy and accountability, and acknowledging that and donors and others, we really need to actually invest much more in this and support CSOs and others to engage, to push for this kind of integration at every level. And I think often we expect advocates to work without financial or other support, and that's often where we see the gaps happening. I do think in recent times we are seeing a lot more, particularly because of the UHC agenda, in terms of some of the siloing breaking down between SRHR and other types of interventions. I can speak specifically to HIV. I think the differentiated service delivery approach is very consistent with rights-based family planning, and a lot of work is happening there in terms of thinking about how we provide services together alongside each other, and also how we think about, even just in terms of operationalizing the WHO guidelines that came out at the beginning of the pandemic. How do we think about providing integrated services for young people, for example, where they already are accessing services? So I think it's nascent, but there are some different areas where we're seeing that integration starting to happen.
Wonderful. Thank you so much. And believe it or not, we are just about at time. So I am going to wrap up. We had additional questions that came in through the Q&A. Thank you so much to our panelists as well as to our participants for joining us this morning and for your very fantastic questions. My hope is that they will be passed along to our panelists because I think these are questions that they can continue to ponder and address in the work that they will continue to do in their day-to-day lives. Thank you so much again to everyone for attending this morning. I hope that the rest of the day also goes really well. I want to remind everyone that each of our speakers really offered some amazing insights into actionable steps that each of us can take in terms of changes that we can advocate for at the various systems level, in terms of engaging either with our policymakers, at the health system level, at the local level, as well as with some of the key populations who are affected. I want to thank you again. My understanding is that in order for you to return to the main event, you need to click on the link for the Lives in Balance Summit. That has just been put into the chat. So please click on that link and it will take you back to the main session. Thank you, everyone, and have a wonderful weekend.